Therapist Eyes Tribe. We are experimenting with well, not experimenting. We're on a new platform. We have our live offices. You'll see us on YouTube. We have a wonderful example of a mother with her son Lucas. How's it going, Victoria? You doing okay there?
It's going.
It is going.
We shall.
Happy
we shall
birthday,
see how
Victoria.
Oh, thank you.
That's right. Miss Victoria had a birthday, so she has been blessed us for we won't say how many years
32
on this earth. All right, this is Through a Therapist's Eyes, and we are getting used to our new panel, our new process, our new thing as John has moved to Bradenton, Florida. This is going to be episode 326, OCD personality disorder, and a little bit of differential diagnosis as well as the title. So if you're finding us for the first time on YouTube, we can start usually about 6:15, 6:30, where you can interact with us live. You can also give us emails at contact@throughatherapisteyes.com. We love to interact with you. And you can do that in the show at YouTube Live. So this is where you get a panel of therapists helping you out with blowing up stereotypes, myths, and misconceptions about mental health, disseminating information. Knowing, Victoria, this is not the delivery of therapy services, right?
Correct.
She always likes to make sure that's the case. All right.
5-star rating.
What's that? Yes, the 5 stars are important. John, do your thing, brother.
Okay. Yeah. Be sure to put us 5 stars rating because that helps us with our those who say with Google or with Apple, and so I appreciate that. We appreciate all that.
Everything's driven by the algorithms these days. Eh?
The algorithms, oh yes.
So this is where you subscribe, click, do your part. We provide you content, hope to entertain you a little bit. Please do follow John. Don't upset him. He wants the 5 stars. Contact at therapisteyes.com. The three. Why do I have a reverb now?
Sorry, I had to readjust my iPod.
Okay. Thank you, Victoria. Thank you for your patience, by the way, listening to this episode with our new pieces. That was another reverb. You're adjusting again? Now, what did you do,
I'm
Victoria?
adjusting to living the bi-high life. I can hear myself talking.
Yeah.
Not now.
Neil, are we okay, bud?
We're okay. I think Victoria's headphones are disconnected. You might be on just your normal laptop because it's reverbing now when you're unmuted, Victoria.
Would you hold second?
We are a ragtag bunch getting used to the virtual. All right, the 3 questions I want you to think about today. What's that, Victoria?
No, go for it. You're good.
Yep. The 3 questions that we're looking at today is what does it mean to have obsessive-compulsive personality disorder? And how is it different from just being detail-oriented per se? And then 2, why is OCPD... Got the reverb again. Why is OCPD often misunderstood or confused with OCD? Because they are very different things, personality disorder versus OCD. And then how can understanding OCPD improve relationship therapy and self-awareness? So I wonder if people even kind of realize that OCD can be a personality disorder as well. Like, I don't think the public kind of realizes or even knows what that is. Yeah,
It's
Victoria, this
different.
was... So I asked Victoria what diagnosis we want to do, and this was actually her idea. So I was like, oh, banging, this is perfect.
Thank you. Yeah, thank you, Victoria.
So why is it not the same thing, and what's the deal with that?
Okay, so do you want me to just go into my spiel about it? Because I have a
I mean, you started us off.
Okay. Yeah. Okay. So OCD, obsessive-compulsive disorder, is where you have an obsession, which is a thought, and then you have a compulsion, which is a behavior that follows the obsession. Like you do something so that something else doesn't happen because of this thought that you have. And that it like impacts obviously your day-to-day living. It's usually through like routines or counting. It can also be like just in your head or like thinking, counting in your head. It doesn't have to be like physical things. Anyways, so like there's that. And then obsessive compulsive personality disorder does not have that. It is basically where you are just so hyper focused on like organization and perfection to where that impacts your ability to like function normally in day-to-day things. So you might ignore certain like morals and values that you have in order to keep this like inline perfection type routine thing in place.
Yeah, I'm wondering if and Victoria, I think that's correct. I think there's also people that would fall in the spectrum of OCD that could have predominantly obsessive thoughts as opposed to compulsive thoughts, or
Yeah.
or compulsive actions rather.
Yeah, but that's still different
Mhm.
than
OCPD, yeah.
that's still different than OCPD. So
Okay.
like
I think every one of us have had somebody that is perhaps a boss that is OCPD. And
so yes. Sorry.
So one of the things that I think is interesting about this, honestly, is first of all, I want to do a segment here in a moment on differential diagnosis. Now, that's really through a therapist's eyes. Like, I don't think the public realizes or understands what happens in our minds and in the process with diagnosing. So we gave you a little bit of a touchstone with OCD compulsions, OCD obsessions, and then OCD personality disorder. And we're going to make a little bit clearer picture of that because I think people get really confused about this. Okay. So first of all, let's go into a little bit of differential diagnosis. Okay. What do we really mean by, what do we really mean, John, by, differential diagnosing?
It's what you may have you may come to a conclusion that this is probably this diagnosis, and then you have to use your reasoning and your knowledge to be able to, and perhaps some intuition. So there's an art to it, where let's say a person that has, it might also be, and you might have to rule it out, another personality disorder or an anxiety disorder or that sort of thing. Could be depression. In this case, I think OCD, personality disorder, or OCPD, you could be someone with autism, for example, or avoidant personality, or let's say schizoid personality disorder. And so you have to rule that out because they have their own criteria that would fit. Let's say a person with autism spectrum disorder would have another set of symptoms. And so you'd have to rule that out and say, okay, this person that it doesn't have ASD, this person has OCPD.
So John, let's back up. Let's back up just a little bit. It makes perfect sense to me, but I think that what I want people to understand, we don't have a lot of time today to talk fully about diagnosing.
Okay.
But, what I want you, the listener, to understand is that we us therapists do have a lot of pressure in the sense that very first session when we're billing insurance companies, we have to have a diagnosis. It has to be medically necessary. And so we oftentimes can get that pretty quickly. We know what symptoms are. We know what to look for. And today we're going to be talking about OCD and OCPD, obsessive compulsive disorder and obsessive personality disorder. We're going to differentiate between those a little bit. But, differentially diagnosing is just a fancy way of saying, hey, we start out with something and we get more information as we go through session 3, 4, 5. And we change that through, John, you were saying, our reasoning and the symptomology and this type of thing. For a younger clinician, I want people to understand, like, it's okay to do that. Like, I have totally changed my diagnosis a year into working with people sometimes, right?
Like, I have. Because it takes sometimes a year to find out what exactly is going on with them.
Right. Because they might not give us information. We find new pieces, new revelations, and that tells us, like, oh, wait, it's not this, it's that. This is a really ongoing component of mental health that I don't think people, generally understand. Victoria, how many times have you changed a diagnosis being earlier on in your career? Because, John, I think we've done it all the time, right?
Yeah, all the
Yeah,
time.
I mean, I probably don't do it like super frequently, but I mean, I have done it. Like, I'm not afraid to do it because if it needs to fit. He's looking at all the Legos in my office.
Uh-huh.
We have Lucas,
yeah, I mean,
John.
Yeah.
Like-
But yeah, no, I mean, I do it, and
the force is powerful within him,
The youngster.
the youngster.
We were making jokes, John, before the cameras came on. We're gonna really test Victoria's ADD reality here today. This is a test run to see how her ADHD can handle Lucas with her.
Yeah. But so I'm sorry. Maybe I missed. It's okay to change your diagnosis, and it's okay to renegotiate it, and I've done that. I think it's important to try to get it right as best you can. We do make mistakes. I've been asked before, and I think Chris, you have as well, to make a diagnosis at court when you go to court.
Oh yeah.
May I not do that, because that's going to enter into their permanent record, court recordings, and you don't want to label anybody.
Sure.
Yeah, you don't want to label anybody. So
yeah, and I've never had a concern or an over big worry about labeling per se, and I think a lot of therapists are terrified about that. But the labeling is a part of what we do, and it, like I said, this is not a show about just diagnosis, but we have to touch on that a little bit because we're talking about switching things up as we develop and as we go along. So, bottom line, that really is okay. And one of the big points here, John, you just made, this actually helps to prevent misdiagnosis. If you give yourself the flexibility to move with the information as you're going along, then you really get it right. But you're not always going to get it exactly right the first go around. Victoria, I'm curious, you as a newer and whatnot, like, how much pressure do you have when you first meet with somebody to kind of get it right, to get a diagnosis, to get this thing on paper?
I mean, I've always been under the same impression of, like, kind of what you've already said, is that, like, because most of the time we're billing insurance, like, we kind of have to give one at least that first go around. And then, but, like, honestly, and I'm usually pretty open with my clients about, like, hey, this is what we're going with today based off the information that you've given me to this point. But, like, as we continue to meet, like, it could change, and it could, it could evolve, or, whatever. And
I love the word evolve, honestly.
And so I don't necessarily think now maybe when I first started out, there's a chance that I probably, felt some pressure to be like, oh my God, this has to be the first go around, and, like, I'm going to get in trouble if it's not. But I think I've kind of worked over and past that, like, over the years, especially, like, my time in agency. And in my time now, like, in private practice.
Yeah, which is a really good point. I mean, I think clinicians, John, really feel this great pressure in agencies even a little bit more. Do you think, like, the Navy, military, all? I mean, that.
Oh yeah. And in the military, that goes into your service jacket, and and that's why a lot of people in the military, at least I dealt with Marine, Navy, and Coast Guard folks. They get really, very kind of, I think, rightfully paranoid about it, that this is going to follow them, or the command will know and find out. So, so you have to be very careful, I think.
But engage, because this this ability to differentially diagnose again helps us all throughout the therapy relationship to make sure we're getting it right, to make sure this is operating in the way with new information as we go along. So bottom line, it is okay to change things up, to move things around, and to engage, in a way where, we move with the information. Differential diagnosis is okay.
Yeah,
and
definitely. And I think you would not be doing your due diligence if you didn't do differential diagnosis.
Right.
Yeah.
And for those people who don't know, in our handy dandy trusty therapy Bible,
Yep.
All 1,050 pages.
Right. There is actually even a section in our thing, I don't know if we can see that, called differential diagnosis under each description. So like right now I'm on the OCPD, and it lists it has a section that lists the differential diagnoses. And honestly, and I don't know if y'all do this, but what I do sometimes when I am diagnosing someone, I pull out my Bible and I like go through these differential diagnoses with my clients to so that they're also aware that okay, sometimes these are some things that I'm also looking at.
I agree. You have to use discretion. However, sometimes you have a client that basically wants to, well, that's what I am. That's what, and
you come in with diagnoses now. Yeah. I want you to call me this.
You definitely have to be aware of that. But if you feel like it's comfortable, or even if you don't go, even if you don't have to go over it, you can even just go through it yourself as a therapist. You don't even have to go through it with your client.
Yeah, that is a very helpful thing. Particularly, I can remember early on when I was working, as a newer clinician, that section in our diagnostic and statistical manual. That's what they were all holding up, y'all, in the YouTube version here. The books, and that there's a whole section, just like Victoria said, and that really helps you to think through, well, did I miss something? And should I have thought of that? And you ask different questions, maybe get different pieces. It's with every diagnosis, our whole system lines out other possibilities that this may be as well. So it helps the clinician. Victoria, I love what you're saying. If the client is involved with that, they feel a part of it, and then we can really, as we say on the show, the human emotional experience, which we endeavor to figure out together. And I say that because we do that in session also.
Yeah, I think also there's the algorithm. The DSM-5 TR is actually an algorithm. We all talk about algorithms now.
Yeah.
And we are an algorithm ourselves, because I've been working with the DSM since it was DSM-3, and that's how many years? Since 1979, 1980. That's a long time.
It is.
And and I've internalized a lot of that. I'm not perfect, but I sort of know where to go.
Same. Absolutely same for me. I started with DSM-3 revised. It was a little bit after that. And it's difficult because there's so many overlapping symptoms. There's so many overlapping components. If you have a lack of motivation, we know that's definitely a part of depression, but anxiety can kind of bring that in too. Sometimes, you have this anxiety situation, generalized anxiety or something like that, and it's wearing people out mentally, and they feel a lack of stamina, a lack of motivation, but it's an
ADHD?
overlapping thing. What's that?
ADHD?
How does that have overlapping stuff?
No, I'm saying it also has a thing for lack of motivation sometimes.
Yeah, it spans across different things. So it's complicated, isn't it? To really get it right, to do diagnosing, the pressure that we have right off the get-go because of insurance to be medically necessary, and we need to give ourselves a break and to understand. This may take some time to kind of get through it. And so you start off sometimes with adjustment disorder and go to other things from that, because that's a basic diagnosis. And then you move into what other things might be. So this is just a little bit of behind the scenes. This is how we make up our secret sauce, if you will, for doing what we're doing, with diagnosing. Okay. So
Correct.
I think we probably can do a whole nother show, and we have a show on diagnosing earlier on. Let's get off of this and begin to get to OCD versus OCPD and how that can be so confusing for people. So first of all, personality disorders. One of the two of you, take a stab. What is different? Why do we have a section of personality disorders? And I'll give you my theory about it.
I mean, because their mental health struggles affect their personality.
Well, they're an early age, aren't they? They come at a very early age when the personality is being formed.
Right.
And so that's something that Victoria, I sense that this occurs sometime after childbirth and in the first 3 or 4 years where it starts to develop, and it's almost like and its problem with it is that it's to the core of the personhood, and so it's notorious. I don't want to cause people not to have hope, but it's difficult to treat a lot of times. And
yes, they really are.
Medication doesn't necessarily work.
That do nothing.
Do nothing. They may be depressed, they may have anxiety, and so that could help. But as far as changing the personality itself, it's very tough. It's rough.
This is a perfect place to introduce my theory that I think I've talked about on the show. John, I think you and I connected about it. You know where I'm going?
Yeah, I think I do. So go with it, man.
Dude, man, I realized this not too long ago, and I don't hear anybody talking about it, but I'm developing a little bit of a theory in my brain that, like, all of the personality disorders, Victoria, they're a different section. They've been held off into a different category of diagnosing than all the other things that we diagnose. And we're confused about this. John, you just said something that's kind of new to me. It happens earlier on in life, and we see that with core social experiences. But I really feel like all of the personality disorders, obsessive-compulsive personality disorder, antisocial personality disorder, people usually, you, the listener, you've probably heard of a couple of these more famous ones, the borderline personality disorder, but there's schizotypal and schizoid personality. All of these PDs, I feel like, are hormone related. I really feel like that
histrionic
is in the endocrine system.
Narcissism
Personality disorder, right? I feel like that's an endocrine system issue, man. I really do.
But it hasn't been studied.
No, it hasn't
at all. And in fact, you try to do a word study or something like that, you just don't see it.
Yeah. I think this is, but every time that we've done revisions of the Diagnostic and Statistical Manual, even in Diagnostic and Statistical Manual 5, which we're currently on, 5 revised, I should say, they didn't do anything with this whole section. All of the personality disorders are exactly the same as they've been for a long time. And I think that's because we don't understand them. And I think that's because we don't understand the endocrine system. Does that sound fair?
Yeah.
Well, I mean, if you think about it, like the whole reason borderline personality people were named borderline personality people is because they were literally on the border between neurosis and psychosis. Neurosis and psychosis.
Say more about neurosis versus psychosis.
Okay, so psychosis is where you do not have a grasp on reality. At all. Yeah. Whereas neurosis is like your things like anxiety, depression, ADHD, like those types of mental health diagnoses, because you're like, even though you have struggles or you have hard times with certain things, you are still able to grasp reality. And so borderline personality people, like they were on the borderline. They weren't enough to like be considered fully psychosis, but then they also weren't enough to be considered like fully neurosis. So they ended up with the name borderline personality disorder.
Gotcha. Complicated, but yeah, I got you.
Well, that's what I'm saying is like, and I think that just goes to show like how much more it needs to be researched because like,
Are we doing witchcraft?
I
So,
mean,
yeah,
we could. Do you
yeah.
want to?
I could see was borderline personality it being in the endocrine system and being that way, especially on how the emotions are just so up or down or empty or whatever.
Yeah.
I don't see it as much, let's say, with somebody with OCPD, for example.
All right, I
But
love that,
could see
John.
it. Okay.
I love that. Let me convince you. Let me go through a little bit of this and see what you think about that. Having said that, because I've thought about this in
Okay.
preparation of this show. Okay, a little bit later on in our show, we planned on kind of giving some examples. Let me give an example of a comparison. So with OCD, okay, we get intrusive thoughts, we get compulsions, we get ritualistic behavior. This is all in one of the two, which, by the way, with OCD, you only need obsessions or compulsions. You do not need both. I think a lot of
Right.
clinicians miss that as well. You feel like you have to have some compulsions, and you
And that's
just
what I
don't.
was saying. Yeah.
Yeah,
Yeah.
you said that earlier. The example,
Right.
John, I always use for that is a 12-year-old kid that I had one time, no compulsions, no anything whatsoever that I could see that would have told me OCD. And this was very earlier on in my career, Victoria, so I didn't really have experience with this. But she was asking really, really inappropriate questions about sexuality, like really detailed questions. Her parents were freaked out. And I was really trying to figure out why or what is going on with this. And what we kind of deduced is that she had OCD. She was just obsessed with this particular area. Okay. So she didn't have any ritualistic behavior. She didn't have any intrusive, well, she had the intrusive thoughts. She didn't have any compulsions, I meant to say. It was really wrapped around all of these intrusive thoughts and just stuck thinking. So it was clearly OCD. So that's what OCD looks like. But OCPD, the personality type, is a pervasive pattern of control and perfectionism. Okay. You really get dialed into the details and you want to make things perfect. So often you see things as beneficial by the individual. Okay. For example, an OCD person is going to say, I must wash my hands or something terrible will happen. OCD makes you believe that. That's where you get the compulsion. But the personality disorder is I must wash my hands the right way because that's how it should be done. Right? There's a
And everyone
personality
else
element
should
there.
do this too.
And everyone else should do this. And if you don't do this, it's a problem. That's there's a lot of that up and down emotion in that, John, also. Right? Just like with borderline. Antisocial is the same way if you think about it.
Yeah, but do OCPD people with this, do they sometimes come across as not being empathetic or?
Absolutely.
Yes.
Right.
Yes.
Yeah. Victoria, go. What is the actual experience like of being around the personality disorder of OCD?
Well, being around the personality disorder, they're so like focused on that, like this needs to be perfect, like this needs to be like we need to follow like all these strict things. We're super devoted, so yeah, then it can like draw their attention away from other people or other things happening, which can appear to other individuals as like, oh, this person is not empathetic, like they don't really, they're only so focused on this one thing that they're trying to do.
And they may not be able to understand why other people don't have that same passion.
Yes.
Yeah.
Right.
Yeah.
It's an intensity level. I mean, we're talking about perfectionism, but it's to the point of dysfunction or really hard. We're talking about a preoccupation, not just a micromanager, but the rules have to be followed in order, in precise fashion. There's lists.
Nurse Ratched and One Flew Over the Cuckoo's Nest.
Well, and I mean, even if you
Nurse Ratched.
Nurse Ratched. Well, I don't know that.
On what I've made a movie reference,
Yes, I know the movie.
One of Jack Nicholson's greatest roles.
Well, yeah.
Yeah. Basically, she followed you had to follow the rules rigidly.
Very
And
rigid.
if you did, yes. And so she kept everybody in line, and she punished people because they would not follow the rules.
Punishing. That's a strong word.
Yeah.
You know, the reluctance to delegate. Like, I can't let anybody else do this because it's got to be done right. And
I'm
they
the only
won't
one
do
that
it
can
right.
do this. Yeah.
Or the only way I'll let other people do this is if they submit to the way that I want it to be done.
Mhm.
I can bust Neil a little bit here. Yes, Neil, I'm talking to you. So we were he was posting the show on the website, right? Now, I'm not saying, let me be clear, Neil does not have OCD PD, so I'm not saying that, brother. But he was posting the show online on our website, right? And I took over that role, take a little bit off of him, and I began to do that. But I could tell he was very anxious. You remember, Neil? He's like, will you get the format right? Will you make sure it's in the right space? Do you have to push the delete and then the enter so that it looks right? Do you remember that, Neil?
Yeah.
Yeah.
Of course
Right?
I do. But you figured out your system. But I had been doing it for so long, and I had to let it go, and it was a good release from my side. So,
Exactly.
yeah, I do remember the struggle.
Right? So that's a normal struggle. That's not a big deal. This happens with a micromanager. I'm not even saying Neil was a micromanager. He was just used to it, and he wanted it to stay the same way. We all feel this way. So with OCD PD, there's an intensity level with that. Neil probably would not have allowed me to take it over because he knows I wouldn't have done it right, and the rules have to be followed rigidly. It has to look the same. Yeah.
Let me give you an example. When I was in the Navy, everything revolves about when I was in the Navy, but we had come from the command chaplain's office. It was not the admiral chaplain, but it was one of the functionaries came up and said, you have to be accountable for every 15 minutes of your time. And we were sent, this is no lie, this is the absurdity of it. It's like something out of MASH, where we had to account for every 15-minute intervals.
Oh my God.
There was, we did it for about 3 weeks, and there was a rebellion of chaplains that said, we can't do this. We can't do our jobs.
Gotcha.
And and that was recorded. And it came about as this was the chaplain who thought that this would be a way that we could prove that we are fully accountable of our time. And all we were doing was recording just writing down our 15 minutes. And it just was ridiculous. We couldn't do
exhausting.
it.
Sounds exhausting.
Yeah, and the command chaplain put an end to that, put the kibosh on that.
Because honestly, personality disorders operate in public, and that may have been do you think that was an example of OCD, OCPD?
OCPD, I do think so. And
yeah.
He was very meticulous about following the rules.
Okay,
and
let me give you a word, and this comes from the research of this episode. I never thought of this way, but going back to your skepticism, John, about the endocrine system. Okay, think of this. This is an egocentric nature.
Yeah,
that's a cool word, right?
Yeah.
Now you're the wordsmith. What does egocentric mean to you, John?
That means self. Ego means I, and and dystonic is, one's outward and one's inward. Okay. So, all right, am I getting that right?
I think so. The syntonic nature of this is that these traits feel correct to the person, and we've already kind of said that.
Right. Syntonic, it does feel correct to the person.
Okay. They often see their way as the right way. Now, what does that sound similar to? Narcissistic personality disorder, antisocial personality disorder, borderline personality disorder has a little bit different flavor. But John, I kind of feel like this syntonic, this egocentric, this I have it right and no one else does or even can is a common thread in these diagnoses.
Yeah, there was a play by Ibsen called The Enemy of the People, and the guy was right about the drinking water was being polluted in a Scandinavian country, but he just alienated everybody because he had to be right, and he alienated everybody. So that would be something. That would be that egocentric. Is that what I'm
I think
hearing
so.
from you?
Absolutely. As a matter of fact, you're saying that. Victoria, remember, I think we talked about this before when I was
Yeah.
getting to know you, and we were talking about the indicator of what you might have missed when you have a personality disorder. Do you remember what that indicator was? Have you used this yet?
Oh, the one that you use personally?
Yeah.
Yeah, if they get on your nerves.
Absolutely. Right?
Yeah.
I have been in so many
Yeah.
sessions when you're not going to bother me as a client. Like I am here. I don't, have
Yeah.
an opinion per se. It's not a personality interaction. There's some
Right.
art to what we do. But sometimes, and I was talking to Victoria about this, it's like somebody gets under my skin, and it's like that doesn't happen normally. If that ever happens, they really got to me, John, and they get under my skin. They're aggravating me, and I'm like, oh, boom, wait a minute. I know what happened. I missed, and always I go back and I get questions and diagnostic questions and symptoms. And guess what I find, generally speaking, when that happens? A personality disorder.
Right.
And I think that's a common thread.
So in other words, if you want to wring their necks, is that they?
Yeah, a little bit.
Yeah.
And even it's just because it's so like your commander in the Navy was just aggravating and bothersome to people.
Mm-hmm.
Neil wasn't bothersome to me at all when he did that. It was like, I get it, Neil. I think I can do this. He saw me do it a few times. He let go of it, and we're good.
Well, I was just thinking all the damage that the commander did.
Wow. You're reliving?
Yeah, I got a knot in my stomach because I was like, it was just unbelievable.
It's gut wrenching.
Mm-hmm.
So Victoria, how does this affect relationships? Do you think, honestly?
How to like personality?
Yeah, OCPD.
Uh-huh.
I mean, it definitely is. We see that you're hiding, dude. We can't see you. If anybody sees Lucas, let me know.
Okay.
But I mean, yeah, because it can like the personality part of it can keep you so preoccupied with like the structure and like the perfectionism that like you might end up neglecting your partner or like putting certain things or starting fights type of thing because they're not doing something the way that you think they should be doing. And so then like, yeah, it can cause tension. It can cause, you might end up, like I said, neglecting certain parts of a relationship.
It's consuming.
Yeah.
Mm-hmm.
Yes.
It's absolutely consuming. Now, we can see on the YouTube that Victoria's being a little consumed as a mom with Lucas. That's wonderful. I love the real life, by the way. Right? But this is normal. And the types of situations, John, you're literally reliving a commander and getting a knot in your stomach because that's
I remembered something from 35 years ago.
Right. I mean, these are personality disorders. This is the intensity level. Like, moms are not going to be frustrated with their kids. It's not like gets under your skin. It gets frustrating. It gets tiresome. It gets all of that. But I'm really trying to drive home.
I think the other thing too is when you work with somebody with an OCD condition, it torments them. They don't want to be like this. They don't want to be like that. They don't want to have that. Right. But an OCPD person is not necessarily aware of it, or if they are aware of this, they again question, why isn't everybody like me?
It's a big difference.
Yeah, it's a big difference, and I think that drives. I think that can drive you crazy.
Did I ever tell you, Chris, that the reason that I thought of this is because I have a client who we are in the process of like diagnosing her with
You did not.
personality.
Okay.
And she's actually very, I mean, she's on board with it. She agrees.
So she has some insight, actually. That's a big step.
Yeah. And that's what I mean. I haven't officially added it to her like chart because we're still like discussing it and exploring it.
You're negotiating, yeah.
But yeah, I mean, this person definitely had like she is almost like why, but that's what reminded me of it is like she is very much of like why is everybody else not like this? You know,
she literally said that. She literally said that.
I had a student that I worked with, and even after I had retired from Montreat, but she would not receive any idea and any feedback that she was absolutely deleterious in her personality that would drive people away. She had actually been she was actually kicked out 3 times out of the program. They kept taking her back, and eventually they had to finally say we can't do this because she was so resistant to change. And so she would be willing to. She had already had gone through 2 other programs before and had been asked to leave. And yeah, and so she was absolutely obsessed with the idea that she was a great counselor and that everybody was wrong and no one appreciated her, and she couldn't figure that out.
Here's something that John, listening to you there, triggers into my brain. When I know we're moving back and forth between OCD and OCPD, but hopefully you're getting an elongated view of the differences here.
Mm-hmm. Yeah.
Because in OCD, there's kind of a jump up in intensity level that I oftentimes go through teaching with clients. And what this intensity level is what parents learn with a little kid with OCD. Like Victoria, if you had Lucas and Lucas has OCD, you would go and do a nighttime ritual, and you would say, okay, Lucas, I love you. Good night. I'll see you in the morning. And if you don't say that in that order, good night, I love you, I'll see you in the morning, then Lucas is going to go 8 nuts, and you're going to have an hour's battle. Okay? But what happens is that kid grows up, and he thinks the world around him is going to subscribe to what he thinks needs to happen, which is, good night, I love you, I'll see you in the morning. But Lucas is going to grow up, and he's going to realize, John, like you say, I don't want to force people into that. I mature. I get out of that. But a personality disorder doesn't. They don't get out of that. They continue that. And it's really prickly and difficult to deal with. So this is why one of the reasons we tell parents, don't do that order. Yes, Victoria, you're going to have a long hour battle with Lucas, but you're really helping him understand the personality piece. You don't have to require other people to comply with your compulsion. So with OCD, it's like you can manage that, John. People don't want to be like that. But when you add this personality element, it's almost like you can't get out of that. You force people into your compulsions.
Right.
Your rules, your rituals.
So I'm wondering, I mean, it's kind of like peeling the onion a little bit, or peeling the grape, because there's some nuanced differences and that sort of thing, and so there's an art to it that you're able to make this determination. And I think so. Again, going back to differential diagnosis.
Yeah. Yeah. You know, I've honestly, Victoria, you're doing something I've never done.
What?
I've never diagnosed OCPD, to be honest with you. I don't know if I probably just missed it or for whatever reason. I've literally never diagnosed that, I don't think.
Well, and the only reason that I've
Mommy, watch it.
okay, I'm watching. The only
Well, they
reason that
probably
I
don't
brought it
present
up-
themselves for counseling.
Yeah.
Well, that's a thing.
Yeah.
And honestly, how we got here, like this person, she's made so much progress. But like that's I mean, she started therapy with me for like completely different things. And through the course, I mean, I've been seeing her for like a year or so now. And so like, but that's the thing, is it's been a year or so and we're just now to this diagnosis.
Right.
And like, you know, and honestly, like I said, it's not even officially on, like I haven't officially added it to like her chart or whatever that we have here. Like it's still like a working discussion, but like, yeah, it's been a year and a half and you know, she started therapy for completely other reasons.
Yeah, that's a perfect example of differential diagnosis and what I'm saying to young clinicians for sure. Like, give yourself that grace, man. At like Victoria's doing. I mean, this happens, John, all the time. Yeah.
What?
Oh, I thought you said what, Victoria?
I did, but to my kid, not to you.
Oh yes, Lucas is hanging with us.
Look.
There's a little segment that I want to do that kind of gets at this. So first of all, to illustrate this again, we've given several examples. Think about a 42-year-old manager struggling to maintain relationships at work, okay? Because he corrects others constantly. He refuses to compromise. He's insistent on doing things properly, right? His spouse describes home life as rigid and exhausting. Like, he doesn't see these behaviors, John, as problematic. Your commander didn't see this as a problem. It's a problem that everybody doesn't follow the law, doesn't follow the rules. And they're holding high standards. This is prickly. This is difficult. This is gut-wrenching.
Wow. I had an associate dean do the same thing at the.
Well, you've been surrounded by this. He's going through different stages of his life, Victoria.
Well, see, you may find this in a hierarchical organization. I mean, I think you'll see this happen more often there than you would. Let's say you're in private practice, and maybe that's why you haven't seen it. I'm not I haven't diagnosed it with clients at all, but I have seen it in personalities of people that I've worked with. Yeah.
Well, to your point, yeah, I've been working managed care therapy for so long. You're absolutely right. I mean, I don't think personality disorders will present to therapy, you know, a whole lot or very easily. Mm-hmm. You know, I didn't think about that, but you're right. That makes a lot of sense.
Yeah.
You know, you'll see this in agencies and Medicare or Medicaid scenarios and, you know, and things like that. Mm-hmm. But if you think about this, you know, this is problematic relationship. And so how do you deal with this, like in marriage, for instance? I was looking at, you know, the book, John, Through a Therapist's Eyes, Re-Understanding Your Marriage and Becoming Your Best as a Spouse. How about that? Right?
Yes.
As one of the big areas of Through a Therapist's Eyes, the focus point becomes a really important piece. Mm-hmm. And I saw that in the books that I wrote. Mm-hmm. And so a partner with OCD can lose their sense of self. That's powerful.
Yeah.
Let me say that again. A partner with someone with OCPD can literally begin to lose their self under the constant correction, the constant rigidity. It's like abusive. There's an abusive nature to this. There's that push and pull and back and forth. Can you imagine, John, doing a personal budget at home with a spouse who has OCD-PD?
Mm-hmm. Yeah. I would. It would drive me nuts. I mean, how's that for a technical term? Drive me nuts. And go to those.
I'll take it.
Go to Looney Tunes. No, yeah. You encounter. I think it's an underdiagnosed condition.
Probably.
I think I'm going back in my long time as a minister, ordained in ministry and at various churches. I've seen it in church hierarchies. I've seen it in congregations with a husband and wife, where the husband was very much convinced was OCPD, and the wife was submissive and was actually
Lost
dependent.
herself.
And so there was a dual dynamic where she was dependent as a personality, and yet she felt like she was always doing something wrong, and was under that thraldom of this guy that was very controlling and was very rigid.
Again, the term occurs to me as almost abusive. Now, we use this term, Victoria, emotional abuse, all the time, and I think people really overuse that word, because when you're in this type of a scenario with a partner, you literally have potential of losing yourself because you have to be submissive. John, you said,
Yes.
that's a big word.
Yeah.
You can't even interject the way that our parenting style is going to be, for instance. No, I know the right way to parent, says the mom with OCPD. And the husband's sitting there saying, well, I mean, shoot, man, I give up. I guess, yeah, we'll go your way.
Yeah. Peace
Just
out.
follow your direction.
Yeah.
Yeah, that's great. Deuces.
Yeah.
And that creates such disruption, because another book component of John, Through a Therapist's Eyes, Re-Understanding Your Marriage and Becoming Your Best as a Spouse. See, John tells me, Victoria, I have to say this multiple times in the show, right?
Seven times.
Seven times.
Yeah.
But the couples are trying to work on shared goals.
Yeah.
Right? Love connections, family harmony, parenting styles. And when a personality disordered person, is driving these rigid details, these rigid rules, this ritualistic stuff, you just give up. I mean, you can't win. You can't discuss it, because this person just keeps driving it home. They don't have that OCD component where the OCD person doesn't want to be this way with other people. The personality disorder almost wants to do that. I mean, even as I'm talking about it, I'm kind of like, man, you get really to the nuts and bolts of it, Victoria. Like, I'm curious, the history of your client, their spouse. Have you guys talked about marriage there? I mean, that's hard?
Yeah. Their spouse is also in therapy.
Okay.
For his own things.
Yeah.
Stop! Don't, dude.
That was to Lucas, the listeners on the show.
Yeah.
She didn't say that to me.
But yeah, I mean, marriage has definitely come up in conversation and in sessions, and yeah, we've have had to explore that side of things and finding, what works best and how to navigate that for them as a couple.
And here's the real. Oh, go ahead, John.
No, I was just going to say, but the challenge would be if the person's not open to change and changing their behavior or their thinking, then it's, I don't know, that the partner that is having to live with an OCPD person would have to say, am I going to be able to stay long in a relationship which absolutely there's no satisfying, there's no sense of one treating me like a human being.
Very little of that, yeah.
Very little of that, yeah.
And think about, so you lose pieces of yourself, we've already said, but to go that a little further, even taking that further, this is your spouse now we're talking about. It's similar but less intense with a boss or a friend even, or a family member, but this rigidity dominates the partnership, and the spouse can seem to feel absolutely unloved. The spouse can feel unseen, unvalued. It's like, I am being controlled here. This person is running me over. It's a sticky, yucky feeling from an emotional standpoint, and the OCDP person doesn't even know they're doing it.
Right.
They're really thinking they're actually trying to be helpful. If I tell you the proper way to to parent Lucas right now, Victoria. Like, I know what you should be doing, and I tell you what you should be doing with Lucas right now. That's pretty pushy of me.
Mother-in-law.
Yeah.
Right?
You might
mean-
you might hear some choice words come out of my mouth if you do that.
And it would be justified. But if you and I had a long-term relationship and I'm doing that and you know that that's going to be the case and I'm going to push into that because my personality disorder goes there, I think you get to a point of just complete resigned.
And
I
that's kind of
can't.
what John was mentioning earlier with like the submission. Like then I just, would end up submitting to whatever you're telling me as a parent I should do. And because I just don't feel like arguing with you or or if everything does turn into an argument because you're not going to understand that like not everybody thinks that way or not everybody would, parent that way or whatnot.
The normal
also,
thinking. Oh, go ahead. Sorry.
While on here, I'm going to have to peace out because little man has to go to bed soon.
He has to go. Okay.
Since we're not home. So we might be doing this from our house next time just so that way we don't have to end early. But yeah, we got to get home so he can go to bed.
That's cool. No, I appreciate that. Check
sorry,
out.
Real quick question. Neil, do I need to leave my computer up?
If you can.
Okay. I can't help it if it goes to sleep, but I can at least leave it on.
Yeah, that's fine.
Okay. Then I will just turn off my camera and mute myself.
Yeah.
Perfect.
Okay.
Peace.
Bye,
Thanks,
guys.
Victoria.
Enjoy.
Appreciate your and by the way, these were
Okay,
examples,
say bye.
Victoria. These
Say
were
bye.
examples.
Bye.
Wait a minute, you got to let me do this.
Bye.
Bye, Lucas.
Bye, Lucas.
Victoria, I gotta say, you're
Yeah.
a wonderful parent. Okay, this was all example.
A lot of patience.
A lot of
okay,
patience.
bye, guys.
So Chris, if you were OCPD, you would have said, you can't do this. You can't leave. This messes with my paradigm.
That's right. The time is to the end of the show, and you have to follow through. And I'm the boss. I'm the big guy, and we contracted from this time to this time, and we have to go to that time. Yeah, no, you're good point.
Right.
And usually people have flexibility and patience in life. We realize things are different, but OCPD people just almost don't have the capacity to do that, right? So there's lots of dangers in this, and I hope people are getting the idea that this is a severity level that's higher than normal. This is not a simple severity level. Right. So what do we do, John? How do we cope with this? How do we manage this?
Well, in a perfect world, the OCPD person would have that self-awareness, and that awakening would happen, and that person would have the sense that I have to change. I don't think that happens very frequently, and it's improbable. But I do think the person that is in a relationship with an OCPD person can say and take stock and say and do some self-soothing and some self-affirmations that it's not me, it really is them, and that they do it with a sense of equanimity, a sense of saying, I will accept the person being very rigid. I will not accept it for my own. I will not be rigid with them. I will be generous and equanimous with them, and I will love them, and they will love me as much as they are capable.
And this is the spouse.
And
this is from the spouse's perspective.
From the spouse's perspective, yeah.
Or the friend, or the employee, even.
Right. We all have. I have a friend who sometimes is self-centered and doesn't want you to talk, and doesn't interrupts and doesn't know when to just say, let the other person talk. And yet I value that friendship enough to let that pass and not let it bother me.
I honestly have a little bit of more, maybe it's still a bit of naivete. I think
Mhm.
it's my eternal optimism, John.
Mhm.
I really feel like if you've listened to this show, you will
Mhm.
find people in your life that you've come across that are like this.
Mhm.
But if you're identifying this, I do believe that person has the ability to change. And I know you didn't say that they don't. You said it's unlikely.
It's improbable or
It's
unlikely. Yeah.
improbable. But I think there's see, I actually love working with borderline personality disorder because I have found that we can absolutely, with proper
But that's the
intervention.
one that you can get the most change with
Okay.
someone. Yeah.
Okay. Well, tell me more about that. I'm curious, but I
No,
wouldn't
no,
have thought
it's
that.
with a borderline personality disorder, you can actually you can actually help facilitate change with them because of the people, there is that sense because they're so tortured,
Wow. Okay.
they don't want to stay that way. They want to get out of that.
Hmm.
And
Okay, I
so,
see your point.
yeah, yeah. So there's a motivate. They're suffering and makes it so that they want to get out of that paradigm, that
I hear
worldview.
you. I hear you, but I could switch it too. I could switch it
Yeah, let's push.
to narcissistic personality disorder. I've had
Yeah,
high functioning people that have literally begun to identify themselves as narcissistic personality.
uh-huh. Yeah.
But it takes a lot of
But
nuance,
those
a
are
lot
mirror.
of
Those are there's men borderline, and there's
oh yeah.
female narcissists. But
Hmm.
but you would see one more than the other. I think narcissism and borderline are kind of mirror
Okay, and
conditions.
you see OCPD as very different.
I see it differently. Yeah.
Okay, interesting.
But I'm not the expert, so
Well, we're all experts here. I
yeah.
mean, really, and I'm learning from you. And honestly, John, I guess again, I already said I haven't diagnosed this, and I think you're right. I just haven't seen this clinically in private practice quite as much. I
Well,
probably
they elect themselves out of counseling. That's what I
yeah.
think. I so they
Okay.
select themselves out.
Well, let's
But
stay on this segment and finish up with what do we do with this? You know, you mentioned insight. I think that's a huge piece of it. The person has to begin understanding
mhm,
and recognize
mhm,
that this perfectionism is creating conflict. It's creating
mhm,
isolationism,
yeah,
and probably to your point, John, that they have to really begin to understand, that this conflict is unnecessary. This
right,
disruption. I am causing this, and I need to settle myself down. I
right,
mean, to quote a longtime friend of mine and colleague, Jeff Shook, I love you, buddy. He's retired now. I've talked to him for years, but he really taught me that basically when you're dealing with a personality disorder, if they stick around in therapy long enough to grow up,
uh-huh.
to mature emotionally, they get smoother.
All right, okay. They're able to adapt. You're
Yes.
right. I think it was psychoanalysis with Freud, for example, and that school or the neo-Freudians that would be they would have that revelation that this is what they're doing to themselves and to others, and so that they would be able to refrain from that. But it doesn't necessarily free them. And I would hope
Hmm.
that my heart, if it's truly as you see the mind body connection that you see
Yeah.
with that there might be some sort of treatment that would be effective that would enable a person to develop the tools of
Empathy.
empathy and
Yeah,
self-awareness,
absolutely. And
because
insight.
if empathy goes, if they get an empathy chip installed, then they would be
Yeah.
that they would actually be able to uh, grow.
And I think that's what we're doing in therapy, John. We're trying to look
Mhm,
at the nuance of their life and to
mhm,
grow that awareness. Put yourself in the other person's shoes.
mhm,
How can you identify this conflict and this rigidity
mhm,
with rules? And I think the
mhm,
OCPD person has the
mhm.
capacity to be able to do that. We have to get as a field into that process with them.
So we're not doing our jobs. I mean, it's not that we don't want to do our jobs. We just don't know what the tools are. We're like trying to treat um, um, we're like a medieval doctor trying to treat some sort of infection with horse dung, for
I
example.
think so.
Yeah.
I think we nailed it. And please understand, our field hasn't been around for thousands of years. It's a relatively new field. And again, I've already said these personality disorder components, we don't understand all that great. And I think that's in part because we haven't even studied the endocrine system and what happens. So how do we educate the clients about that? So we have, I'm developing more through this conversation, honestly, in real time, a belief that we
that
need
would
to
be
take some serious steps.
Yeah, compassion. If you're someone that lives in a family like that, or with someone, that you would show that compassion. Yeah, it's hard, but you do it. Yeah.
But here's another component of how do we cope with this? Okay, big caption here: avoid power struggles.
Yeah, definitely.
When you're in a relationship with somebody and you kind of identify, or they're identifying OCPD, obsessive-compulsive personality disorder, you really don't need to get into power struggles. It's not going to be pretty.
I agree with you, and I think a person with OCD, you're not going to be in that power struggle. So it's very different.
It's very right. You're right. OCD people, they can shut it down. They're like, okay, I know you don't need to clean that kitchen sink 20 times. Okay, I get it. I'm sorry. But it feels like I do.
Yeah.
An OCPD person is going to be like, that's the proper way. That's the only way. That's what needs to happen.
That's the way God would want it,
Right. Right. It's so powerful. And I think as a field, we're really kind of needing to catch up, John, and get this, going a little bit.
Yeah.
What else do we need to wrap up with? Boundaries is another big thing. How do you set boundaries? How do you manage that relationship? You've got to be able to say no when you mean no and yes when you mean yes. And if you're in a relationship with someone with OCPD and they're telling you the only way to parent your child is to do this, you've got to be able to hold that line, John.
So in other words, it's an art, and it's also a skill that one would have to learn, and that is, how do you assert yourself without coming across aggressively? Because as soon as as long as you're aggressive, that person is not going is actually going to reify that boundary.
Because now you get into the power struggle,
and then they'll push you back and push you down and beat you down. Whereas if you step outside of the game, so to speak, then they're kind of they're going to be uncertain about where they stand. So let me
ask you a question. I genuinely don't know the answer to this, and I'm curious, John, because I'm hoping that you do. How much do you think OCD-PD is found in domestic violence?
Oh, I would think it's quite a bit.
Yeah? I never thought of that before.
Yeah.
Have you?
Yeah. Well, the thing is, I don't know. I'm wondering, because a lot of domestic violence, there's substances that are used quite a bit. Would an OCPD person necessarily be abstemious, not abstemious? Would be a user, an abuser
of substances?
I don't know.
I wonder what the correlation is between addiction and alcohol abuse, if not addiction and OCPD. That's probably a thing. They're stressed out too. They got to find a way to cope.
Well, that's a good research topic. A good dissertation I should have done.
It really is, isn't it? Yeah. I think it is. Man, I think in winding down here, speaking to our field, we have a lot of work to do in this area.
Yeah.
That is really clear to me through this conversation.
Yeah.
Let's move to the last segment of the show. We call it the shrink wrap up. The shrink wrap up. This is where we take a little friendly competition moment to sort of wrap up the show, summarize the show. We each take a turn, and Neil gets to decide who kind of did a better wrap up. So the shrink wrap up. I guess we're head to head on this one, John. What do you want to play? Rock, paper, scissors. See who goes first.
I don't care. I'll say that a person with those that we need to approach the OCPD person with compassion, with a seeking of understanding, even though they may not display that to us. I think it's possible to live with somebody with OCPD and be in a relationship, but I think it can be very challenging. I, I'm hoping that there is going to be more research in that and help so that we might be able to find a way to assist people through treatment.
I love that. Yeah, I think one of the biggest things we need to start with is identifying this, and it's hard to identify. And so give yourself some grace as a clinician, but then also just as a person who may have OCPD. But then when you identify this, I have hope for us and the people that we serve that we absolutely can identify the characteristics and help you to gain insight about this
Mhm.
so that you can move through some of the strategies in the relationships and improve them so that you're not having a constant battle or constant pain that creates 30 years later John has a gut-wrenching feeling, a knot in his stomach about a person
Mhm.
whom he related to. So I think that we can make an impact on that, but we have to be really on point and careful with the nuance in how we do that. But there
Right.
is hope about this. This is hard, but it's doable.
Mhm.
All right. I'll
Definitely.
turn it over to you, Neil. How'd we do, brother?
Those are two really, really good recaps. I would think that for today, based on the show and how we talked about it, I like Chris. I like yours today.
Yay.
So you got this one, Chris. I really should be keeping track of this.
You need to start taking a little tally. I think so. I'm gonna ask you to do that. We'll get a special prize at the end of the year, John.
Yeah, you know what, Neil? You're full of beans. I'm right, and you've got to conform to my way of thinking and acting.
Wow.
Okay.
Well, if you didn't do the shrink wrap up the correct way, I would have given it to you. But
I think
I
that
think
is
we
an example
understand.
of
I think we got it.
OCD. That
Yeah.
is OCPD in action, man. Good stuff.
Okay.
Good stuff.
All right. Hey, God bless. I'll see y'all.
Absolutely,
Thank
John.
you.
It's lovely to see you. Stay on. Don't leave so quickly this time, real
Okay.
quick, by the way.
Okay.
But good to see you. To the audience, thank you for your patience. We're learning a new platform. We got childcare with Victoria. Hopefully that wasn't too disruptive. We'll get better at this platform, I think, as we get comfortable with what we're doing. So we will see you guys next week. Stay well until then. Take care.